We can click that to say okay. And for those who don't know me or who are new to our sessions, I'm Maria Markowitz, and I'm part of the hub team here in the Georgia Cancer Center for our TeleDerm project. So Dr. Doug Patton and I will be co-facilitating the session today, taking turns. And I would like to ask you all to have your cameras on if possible, and to use gallery view so when we aren't looking at slides, we can all see each other and talk to each other. So you might have noticed, and Brenda, the next slide, you might have noticed that in my opening greeting, I said we were Teledermatology Serving Georgia, a title a bit different from our old title. And this is because we've entered phase 2 of the teledermatology project, and it's changed a little. And so we changed our name to better reflect the clinical changes that we've made. We've also updated our website. That's a work in progress. It's still being updated, but I wanted to remind you about the TeleDerm website, or for those of you, a number of you, I think, are new to our sessions. And so I wanted you to know about our website, which has a great deal of very good information on it. We have training videos on there, which you can, if you watch it in the correct mode, you can get CME credit for. And we have links to all of our past TeleECHO TeleDerm conferences, so you can look through and see some titles, and you may want to log in and listen or watch those sessions. Let's see. I think everyone, we'd like you to be putting into the chat your name, your affiliation, and your email. Lots of examples there that people are already doing. I also, at this time, want to welcome back Dr. Kendall Buchanan, our dermatologist and great leader, and she's been out on maternity leave, so we are thrilled to have Dr. Buchanan back with us. And I want to welcome all of our other participants. Some of you are primary care providers from the rural health centers that participated in our first part of this project. And there are other clinicians or administrators from the East Georgia Healthcare Center who may be participating for the first time and will be participating in this phase 2 of the program. We have residents and faculty from MCG's family medicine program, a family medicine residency program, I should say. And we may have residents from the Phoebe family medicine program down in South Georgia. And certainly we have faculty and residents from MCG's Department of Dermatology, including our dermatologist, Dr. Loretta Davis. I've mentioned Kendall Buchanan and Dr. Harold Rabinovitz. And some MCG medical students, old students and new students. And then members of the Georgia Cancer Center TeleDerm team. Brenda and I are handling the controls today, and we're not in the hub, we're in our respective offices. And then I also want to welcome any participants from other parts around the globe whom we sometimes have. And then certainly anyone who is attending this our TeleECHO session for the first time, we certainly welcome you and hope that you will return. Let's see. So if we can have the next slide to review the agenda. I've done introductions, and then we will have our didactic session presentation by Caitlin Blanchard, Dr. Caitlin Blanchard, who's a third-year resident in dermatology. And then Sarah Hanna, a third-year medical student, will be doing the case presentation. And then we'll wrap up with discussions and announcements. So now I will introduce you to Dr. Doug Patton, who will take over the session. Dr. Patton is the Dean of the Southwest Georgia Regional Campus of the Medical College of Georgia, and he spent most of his career as a rural physician. So, Dr. Patton, take it over.
Thank you very much. It's good to be here today. And as usual, we'll kick this off with the normal announcements. Again, just a reminder of Project ECHO's mission and what it stands for, the Extension for Community Healthcare Outcomes, but it's moving knowledge instead of people. Next slide, please. So we aim to improve knowledge by use of telemedicine, in this case, teleeducation about teledermoscopy and teledermatology, so that at the local level, you can enhance the care that you're able to provide to your communities where you are, and also be connected if you need assistance with referrals and things like that. This is our way of trying to help address some of the health disparities faced by people living across the state of Georgia, primarily in rural areas. Next slide, please. So sessions are recorded, as was previously mentioned. You are consenting to being recorded by participating and remaining logged in. And because these are not secure connections and not consultative in nature, it's important that we remember not to mention PHI or display any PHI in our presentations. There is, however, continuing medical education and nursing education credits available, and that information will be on the final slide. And you can always email teledermatology@augusta.edu for questions. Also, the chat is forever available, and we will watch that carefully. Next slide, please. So these are the reasons that we collect data, and it begins with registration and follows through with the entire presentation, including chats and recordings of the sessions, as Dr. Markowitz mentioned earlier. These sessions are all recorded, archived, and available for replay or perusal at your leisure anytime. Next slide, please. So just the general Zoom reminders. As she said, we hope that you can keep your cameras on. If you're like me, I just got high-speed internet at my rural location in my home. So I can now have virtual meetings without turning my camera off because of bandwidth restrictions. So if you can do that, that's great. Raise your hand if you need to speak or if you need to ask a question. You can always type into the chat. Even though we've been doing this now for about 5 years, just as a reminder that you do have to unmute to be heard. So Ken's is available if you have things. So with that, we're going to move into our first didactic presentation. It's my pleasure to welcome and introduce Dr. Caitlin Blanchard as our featured guest speaker today. She is a third-year resident in the Department of Dermatology at MCG, and she's going to address something which is commonly managed in many primary care settings, and that's leg ulcers. She's going to talk to us today about some tips and tricks and things to look out for with leg ulcer management. As Dr. Blanchard completes her program, she will take off her last slide and we'll open it up for question and answer. If we have a few questions, you can ask those questions throughout by posting a question in the chat. We'll be moderating that chat and making sure that we get all questions answered. But again, if we get to the end of the presentation and you want to speak a question to the group, that is an option also. With that, I'm going to turn it over to Dr. Blanchard, and if we can have her slides, please, that would be great.
Good afternoon. I'm going to go ahead and share my slides now. Can everyone see those okay?
You can. Thank you.
So my name is Caitlin Blanchard. I am a PGY3 dermatology resident, and I will be presenting on leg ulcer management today. So to start, I wanted to briefly highlight why this topic is so important. Leg ulcers, particularly venous leg ulcers, are common with a prevalence rate of about 1 to 2% in the adult population. In addition to being common, leg ulcers are costly for our healthcare system. Chronic wounds in general are responsible for $7 billion per year in annual healthcare costs worldwide. Furthermore, the average cost for one treatment episode of a venous leg ulcer in North America is estimated as $16,000. Given that leg ulcers are common and costly, let's further discuss them and their management today. To discuss ulcers, we first need to understand normal wound healing, which characteristically occurs in 3 to 4 overlapping phases, depending on the source, as not every source isolates hemostasis as its own phase. For our discussion purposes, the first phase is hemostasis, which occurs almost immediately and is characterized by the formation of fibrin and platelet plug. The next phase is the inflammatory phase. During this phase, neutrophils phagocytose bacteria, degrade matrix protein, and attract more neutrophils and macrophages. Additionally, macrophages, which are arguably the most important inflammatory cell in wound healing, phagocytose pathogenic organisms, degrade debris, and stimulate granulation tissue formation. The third phase, or the proliferation phase, begins at about days 5 to 7. The proliferation phase encompasses fibroplasia, granulation epithelialization, and angiogenesis. Fibroblasts are essential for proliferation and lay down important structural elements, including collagen, elastin, and extracellular matrix proteins. The final phase of wound healing is remodeling. This phase lasts the longest, and it can take up to a year for wounds to fully mature. Poor wound healing occurs when there is disruption in any of the phases of wound healing. It is characterized by chronic inflammation, cellular senescence, poor cytokine milieu, and critical bacterial colonization. Additionally, chronic wounds have increased levels of cytokines and proteases that destroy essential extracellular matrix components, growth factors, and growth factor receptors. This will help us understand the difference between acute and chronic wounds. Essentially, acute wounds progress through the phases of wound healing in a normal and timely manner, while chronic wounds do not. Table 1 on this slide is from an article in JAD and describes differences in terms of bacteria and cells in acute and chronic wounds. As you can see, acute wounds have low levels of bacteria, low inflammatory cytokines, and low protease levels. Conversely, chronic wounds have high levels of bacteria, particularly MRSA, and high cytokines, proteases, and reactive oxygen species levels. Table 2 is from the same JAD article. And this table lists some of the many factors that contribute to poor wound healing in chronic wounds, a few of them being age, malnutrition, various medications, and then as well as unfavorable local environment, etc. We'll next discuss etiologies of ulcers, as it is important to determine the etiology to aid in workup and management. The most common types of ulcers are venous leg ulcers, arterial ulcers, and diabetic foot ulcers, with venous ulcers by far being the most common type of ulcer. These ulcers classically arise anywhere on the mid-calf to right below the malleolus. Their classic presentation is demonstrated on the left part of the slide, and they are often accompanied by lower extremity edema and hemosiderin changes. Arterial ulcers are also common. They usually arise on the distal extremities and sites of trauma, such as bony prominences. Their borders, unlike the borders of venous ulcers, are classically sharply demarcated. The wound is typically dry, and signs of arterial insufficiency, such as cool surrounding skin, are typically seen. Pain is often severe in these patients. Finally, diabetic foot ulcers usually arise on the plantar surface and in areas of repetitive trauma. They are characterized by punched out borders with surrounding skin breakdown and are associated with distal paresthesias. Listed on this slide are categories of less common etiologies of leg ulcers. Discussing each of these is out of the scope of this presentation. However, it is important to know that ulcers can be the result of many different etiologies. The biggest takeaway from this slide is that biopsy should be pursued in patients with ulcers of unknown etiology or chronic ulcers unresponsive to typical treatment to aid in diagnosis and rule out malignancy. Clearly, the etiology of leg ulcers is complex. I included this flowchart from an article in JAD because I really like how they simplify the workup. They break it down into location on the foot or leg, For those on the foot, a diabetic workup is definitely indicated. For those on the leg, vascular workup is the next best step to determine if there is venous or arterial disease. For either side of the flow chart, if workup is negative, that is when biopsy and further workup for more unusual etiologies of ulcers is indicated. And now on to management, which we will discuss for the remainder of this presentation. The key aspects of management are listed on this slide. We'll start with wound care and wound dressings. In terms of wound care, wounds can be cleaned with either normal saline or tap water. Detergents, hydrogen peroxide, and concentrated iodine solutions should be avoided because of the tissue damage and toxicity. Cleansing wounds in dilute vinegar and/or dilute bleach can have significant antimicrobial effects. Dilute vinegar is particularly helpful in chronic wounds that are prone to frequent infection with Pseudomonas. Any ulcers with extensive slough or necrotic tissue should be debrided. Vaseline is especially beneficial and is typically applied to the wound base prior to wound dressing. Furthermore, avoiding use of topical antibiotics such as gentamicin and neomycin should occur, as they are frequently causes of allergic contact dermatitis and chronic wounds. If there is a concern for superficially infected wounds, preferred topical agents include dilute bleach and dilute vinegar, which we just highlighted a little bit, low concentration Catamexor iodine, topical metronidazole, silver, and manuka honey, as there's some evidence that all of those can help with superficially infected wounds. Obviously, if there is concern for infection deeper, that's when we would reach for our systemic antibiotics. Moving on to wound dressings. A moist but not wet environment is ideal for wound healing. Importantly, skin surrounding the ulcer should be kept as dry as possible. Furthermore, choice of wound dressing should be based on factors such as the amount of exudate, depth of ulceration, presence of slough, etc. So here are some of the many different types of wound dressings. I'm just going to go through them briefly and talk about kind of pros to them and what you would reach for these different wound dressings for. So starting with semi-permeable films, these are best for flat, shallow wounds with a low to medium quantity of exudate. Importantly, it can result in fluid accumulation that can leak, so that's something to counsel patients on. Hydrocolloids are things like Duoderm. These are best for flat, shallow wounds with a low to medium quantity of exudate. And then Aquacel is kind of another variation that's best for flat wounds and undermining wounds with a larger amount of exudate. Importantly, yellow-brown gel is frequent with these dressings, and so it's important to counsel patients that this can occur, as it can often be confused by patients with infection. Moving on to hydrogels, these are things like Intrasite and Nugel. They contain a large amount of water, so they're best for dry and necrotic wounds. Importantly, they are poor bacterial barriers and often permit proliferation of gram-negative bacteria. Next, we'll talk about foam, which is kind of along the lines of the Alvin brands. This is it's bilayered with hydrophobic and polyurethane sheets and hydrophilic surface, so it's best for mild to moderately exudative wounds and wounds over bony prominences. And finally, we'll talk about alginates. These are derived from seaweed and they are highly absorbent, so they're best for undermining wounds with a high amount of exudate. And again, they get that yellow-brown gel that can be confused with infection, so important to warn your patients about that. This is the same slide, but just shows a picture kind of version of all of the different wound dressings, just so you guys can familiarize yourself with them a little bit. Another mainstay of treatment is compression therapy, which is crucial to allow wounds to heal appropriately. Listed below are the recommended pressure gradients for compression stockings based on kind of what you see clinically. So the lowest strength are the 15 to 20 is for mild varicose veins, minor leg swelling. 20 to 30 is kind of those moderate to severe varicosities, moderate edema. And finally, you have the highest strength, which is 30 to 40. Another mainstay of compression therapy is leg elevation. So we always counsel our patients to kick their feet up when they get home and help move some of that fluid off of their legs. Importantly, patients should be warned to remove the garments if they notice any side effects of numbness, pain, tingling, or dusky toes. And kind of along those same lines, compression is contraindicated in those with an ABI of less than 0.5, and really anything less than 0.8, you want to be sending them to vascular surgery. Another form of compression that we utilize frequently is Una boots. Una boots are an inexpensive and non-invasive treatment strategy in which compression, antioxidants, physical restraint, and improved topical medication absorption enhance healing as well as quality of life measures. Typically, when we have them placed, our patients will come to our office about once a week. The nurses place the Una boot, they go home with the Una boot, and then ideally they leave it on for that entire week. And so really get good compression, and then also minimizes kind of anything that could possibly be contaminating that wound. Of course, some patients can't tolerate them, and so that's kind of when they become an issue. Next, we'll discuss medication management. First, a thorough medication review should always be performed. Many patients with chronic ulcers have an extensive medication list. If these patients are on medications that can exacerbate lower extremity edema, such as calcium channel blockers and gabapentin, these medications should be switched if at all possible. I next wanted to highlight 2 medications that we frequently use in clinic for chronic wounds. The first is topical timolol, which promotes reepithelialization and overall healing in chronic wounds. One recent study examining 55 chronic wounds of various etiologies examined wound surface area before and after topical timolol application during dressing changes, which usually occurs daily or every other day. Of these 55 wounds, 34 had completely healed after 4 weeks, 15 had improved, 4 were unchanged, and only 2 had worsened. The dosing is 1 drop per centimeter squared, and again, it's usually applied during those dressing changes. Silver nitrate is another medication that we frequently use in clinic, and it's on the right of the slide there. It works by decreasing matrix metalloproteinases, which are upregulated in chronic non-healing wounds. They degrade extracellular matrix proteins, which are important in normal wound healing. And so that's how the silver nitrate kind of works against that. Next, we'll briefly discuss the role of nutrition and supplements as part of medication management. Several studies have indicated that nutritional deficiencies are more prevalent among patients with chronic wounds. Malnutrition may alter the inflammatory response, collagen synthesis, and wound tensile strength, all of which are crucial for wound healing. Although the specific role of nutrition and supplementation in wound care remains uncertain, it is necessary to identify and correct nutritional imbalances to avoid any potential deterioration of the healing process. I found this interesting diagram from Wound Care Advisor that breaks down nutritional support based on timeline of wound healing. While more research is needed, nutrition clearly plays an important role in chronic wounds. So kind of in the inflammatory phase there, you can see that vitamin A, bromelain, protein, and vitamin C all play somewhat of a role. So important to kind of make sure that those nutritional supplements are appropriate in patients with wounds. And again, proliferative plays vitamin C, glucosamine, vitamin A and zinc, and then protein for the remodeling phase. Next, we'll talk about lifestyle modifications. So, of course, it's important to maximize treatment of any comorbidities, including diabetes, any vascular disease, obesity, etc. Smoking is crucial. We are constantly talking to our patients about smoking cessation, referring to them to our smoking cessation program that we have here, etc. Just because since a vascular etiology is commonly at play and kind of contributing to these poor wound healing and things like that, anything that's damaging those vessels can, of course, it makes sense that it's going to delay wound healing even further. Weight loss and exercise are also crucial, and then minimizing trauma to the area because oftentimes trauma is kind of what initially starts these ulcers, and so of course we don't want them to get more if we can help it at all. Leg ulcer management is a team sport. It requires the support of the patient, family, and many healthcare providers. Depending on ulcer etiology, some of the players on this slide play a larger role than others. For example, vascular surgery should always be consulted if the ABI is 0.8 or less. Given that leg ulcers are typically chronic, we always encourage family and friends to be involved and supportive in patients' care. And again, this slide just kind of highlights some of the many different players in wound care management. Okay. Finally, I wanted to briefly highlight common coexisting diseases, which are listed on this slide. Stasis dermatitis, also known as stasis eczema, is common and frequently seen in those with venous insufficiency. Stasis usually doesn't have systemic signs or leukocytosis, and it's typically itchy and commonly bilateral. Treatment is with topical steroids. Contact dermatitis is another common coexisting disease. It usually occurs as a complication of therapy due to topicals with neomycin, bacitracin, lanolin, or paraben preservatives. Treatment is to discontinue the suspected offending agent and topical steroids as well. For both stasis and contact dermatitis, triamcinolone 0.1% ointment is usually our go-to. For acute flares, we recommend using the topical triamcinolone twice daily for up to 2 weeks. Finally, cellulitis is another confounding disease, which can sometimes be challenging to diagnose. Cellulitis is characterized by erythema, pain, and swelling. I find the ALT-70 score, which predicts the likelihood of lower extremity cellulitis over other diagnoses, to be a helpful diagnostic tool. It accounts for asymmetry, age over 70, white blood cells over 10,000, and heart rate over 90 on initial presentation. You get 3 points for asymmetry, 2 for age, 1 for white blood cells, and 1 for heart rate. A score of 5 or higher indicates that treatment is necessary. All right, so moving on to some take-home points. Leg ulcers, particularly venous ulcers, are both common and costly to our healthcare system. Determining ulcer etiology is crucial in dictating appropriate management. Management is complex and includes wound care, compression, medication management, lifestyle modifications, an interdisciplinary approach in treating any superficial infections, and then have a low threshold to biopsy ulcers of unknown etiology or chronic ulcers unresponsive to typical treatment. These are my references, and that is the end of my presentation, so I will stop sharing my screen. And I think we will take any questions now.
Thank you, Dr. Blanchard. That was very helpful. Appreciate the way you broke those down into the different main categories and addressed some of the things. I was looking at the chat and I don't see any questions over in the chat, but we'll certainly entertain if anyone has a question from the room itself. If you'll just raise your hand and open your mic, we'll be glad to let you quiz the expert. So. While we're waiting to see if someone else will ask a question, can you give us, I guess, the ALT-70 score? That's something that's new for me, and that we know that there are a lot of scoring tools now for all sorts of things, including congestive heart failure and everything else. So this one's sort of new to me. In your references, is there something there to guide us to the ALT-70 score and help us understand, or should we just Google that?
I didn't include it in my references, but it's on MD Calc, which is an app that people often have on their phones, and I can also send one of you guys kind of a link to an article about it, if that would be helpful, that you could send out to everyone. That would
be great. We can certainly include that in the notes for that going forward. And I'm giving away my age here because I don't have MD Calc on my phone. But that is what I hear my students talk a lot about in terms of being able to identify the sort of the menu of scoring systems out there. So that's great. Thank you for that.
Of course, they make it super easy to really just like click yes or no, basically, for all of the questions that it goes through. So it's, I think it's a super useful
so MD Calc, I'm going to have to download that app now so I can keep up with my students. Thank you. Any other questions or anyone out there? Because I have one more before we move on to our student presentation. But don't see anybody. We talk a lot, you were pretty specific about the referral for vascular surgery for arterial insufficiency. And we know that one of the complications, obviously, if you mistakenly identify an ulcer as being venous and it's actually arterial, putting on compression garments, as you pointed out, or any kind of compressive dressing is contraindicated because it can make it worse. But we also know now that with venous insufficiency, there are interventions that are available surgically to help manage some of that. Can you talk a little bit about how venous insufficiency actually contributes to ulcer formation or perpetuation of non-healing states? And then what do the therapies do? Can you share on that a little bit?
Sure. So, venous insufficiency, the way I think about it on my own is kind of leaky valves, so you get a ton of fluid. And so fluid on the legs is typically bad for the skin, and that's because anything that's good for the skin, it can't get there because of all the fluid. So I kind of think of the fluid as a barrier, and so anything that could be helpful and all of those different things that we talked about at the beginning in terms of normal wound healing, when you have fluid on your legs, all of those cells that need to get there to help with the normal wound healing can't get there. And so essentially, treatment is targeted at getting that fluid off the legs. So we always start with compression. Now, patients aren't always compliant with compression, which is why I wanted to highlight Uniboots, because I think that can be a way to force our patients to be compliant. If they can tolerate them, they often will take them off at home anyways. But that's kind of, that's one thing that can be helpful. And then of course, like sending them to, so just like with arterial disease, sending them to a vascular surgeon who can help fix those varicosities and decrease the amount of fluid that's kind of leaking off from the legs can be super helpful too. So I think, start with more conservative, start with leg compression, et cetera. And then if that's not working, that's when we would kind of send them out to the vascular people and those who can do more than we can.
Great. So I think one way or the other, it is all the therapies are meant to overcome the back pressure, if you will, which causes that fluid accumulation. So you can do that with compression externally, or you can do it by obliterating some of the venous channels, and that's what some of the non-invasive folks are doing in their ambulatory surgery centers. So that's good. I did find, to your point about Uniboots, we didn't have a dermatologist in South Georgia that was interested in treating leg ulcers. So my partner and I did an awful lot of that. And it seems that one of the benefits to Uniboots is that these kinds of leg issues and ulcers around them tend to create itching. A lot of itching makes the skin itch a lot, and the Uniboots actually seem to help. And I don't know if it's the zinc oxide or just the combination of the persistent pressure or what, but that was one of the side benefits to doing that. So I don't know if that's been your experience or not, but I find that to be helpful. All right, I don't see any other questions or anything. Stick around, Dr. Blanchard. We may have some other opportunities for you to contribute as we go further into the program. But at this time, it's my pleasure to introduce Sarah Hanna, who's a third-year MCG medical student, and she's going to do a case presentation for us. So Sarah, are you driving your slides, or are we driving slides for you? There you go. I can see it.
And if I can interrupt just before Sarah starts, a number of people came in late during the last presentation, and I'd like to remind you to please list yourself, go to the chat and give your name, your affiliation, and your email in the chat so we have it for our records. Thank you. Go ahead, Sarah.
Thanks. Go take it away, Sarah.
Okay, thanks, y'all. Hi, everyone. I'm Sarah. I'm a third-year medical student at the Medical College of Georgia. Thanks, Dr. Blanchard, for that lecture. It's a perfect segue into what I'm going to go over, as our cases are going to include leg ulcers. And before I get started, I also want to thank Dr. Benebits for these cases. This would not be possible without his help, so thank you. And then also thank you to Dr. Buchanan for helping me get these ready. I appreciate it. So let's get into it. There we go. Okay. Just a quick recap before we get into the cases. The two most common causes of leg ulcers are arterial and venous ulcers. So really quickly, I want to compare and contrast these just so we can refresh it. So in patients that have arterial leg ulcers, these are going to be patients that have atherosclerotic disease. They may or may not have diabetes. Common locations for these ulcers include the toes, the heel of the foot, the bony prominences of the foot, and these ulcers can appear punched out, which you can see really well in this image below. And the surrounding skin can be shiny or cool to the touch or hairless, and this is because of that arterial insufficiency. And then I want to contrast that with venous ulcers. So typically in a patient that has venous ulcers, this is the patient who has venous insufficiency. You can see pitting edema. You can also see hemosiderin deposition. And these are really common around the medial malleolus. That's what this image below, you can see that's where that ulcer is. These typically have a fibrinous base and a gently sloping edge. And so I know Dr. Blanchard went into this, but I wanted to quickly recap it. And then as we go into the cases, I really want to challenge you guys to include neoplasia in your differential diagnosis. So this is our first case. We have a 75-year-old male. He has a history of multiple non-melanoma skin cancers. He was referred to dermatology for a non-healing ulcer on the left leg. You can see it in the picture here on the right. And he had been treated in a vascular unit as if this were a venous ulcer, but he had no improvement. This is a closer up picture. You can see the heaped up borders and the granulation tissue. And then here on the right, we have a dermoscopy image. You can see some vessels, but the dermoscopy features are still non-specific. Would anybody like to unmute and take a stab at what they think the diagnosis is?
Come on, it's a safe space. Somebody take a stab at it.
I promise it's not for a grade. It's okay. I'll let y'all be shy on the first one, but we have some more. So the biopsy results, this came back as an infiltrated basal cell carcinoma, and it was ulcerated. It did not have perineural invasion. This was classified as high risk based off the location, the fact that it was ill-defined, and the subtype, and so Mohs surgery was scheduled for this patient. And I would like to say that typically a basal cell carcinoma presents as a pearly pink papule. It may have focal granulation tissue or focal ulceration. And so when you have a basal cell that doesn't present with a lot of those features, it can be difficult to tell what it is. And so you might wonder, is this a wound that's healing? Is this some type of ulcer? Is this a basal cell? And so one of the clues is if you see a lot of granulation tissue, and then also in our case here, if you have something that is just not healing. And so this image here on the left, this is the basal cell being marked up before Mohs surgery. And then here on the right, it took 2 Mohs stages to clear. And so this is what it looked like after it had gone through Mohs surgery. This is our second case. We have a 58-year-old phenotype 5 woman who is referred to dermatology from the emergency room due to a painful enlarging ulcer on her heel. You can see the image over there on the right. This had been present for over a year, and she was being treated with curettage for a presumed pyoderma gangrenosum. Of note, she didn't have any history of diabetes or any history of trauma to the site, and this had been debrided by podiatry twice, but no tissue was ever sent to path. Okay, would anybody like to take a guess at what this one is?
Squamous.
All right, good guess, but this is actually a melanoma.
Melanoma.
But thank you. This is an amelanotic acromelanoma specifically. They tend to be large and have multiple colors. And then of note, just something to keep in the back of your mind, acromelanoma has a higher incidence in non-white patients. And then the clue here to prompt the biopsy, this patient had this for over a year. It was non-healing and it was getting worse with debridement. And so that should really prompt a biopsy. Okay, I'm giving you no background information on this one, just an image. Would anybody like to take a guess? All right, no takers. This is a basal cell carcinoma. So if you look at the image, you can see the excessive granulation tissue, the elevated rolled border. This one does have a little bit of focal ulceration. And then the clue here is this one looks a lot more like a basal cell. It's got the pearly, shiny appearance, and the central ulceration, which is not uncommon for a basal cell carcinoma, and this was treated appropriately. And then again, I'm just going to give you guys the image if anybody would like to take a stab at what they think this is.
Give us a clue.
A clue. What if I told you that this patient had previously been burned in this area?
Okay, that's a good clue. Somebody take a stab.
Melanoma, squamous cell.
This is a squamous cell. So this is a Marjolin ulcer. It's actually a squamous cell carcinoma that arises in a site of previous trauma or previous burn or chronic ulceration. Note the raised thickened borders. So this is really characteristic of a Marjolin ulcer. They have these thick, firm, raised borders. You can see it really well in this case. And they occur in about 2% of burn scars, so not super uncommon. And then I said that they occur in previous sites of trauma, burn, chronic ulceration. These typically occur a few years after the inciting event. And then this is our last case, if anybody wants to take a guess.
Clue worked last time. Give us a clue.
I would describe this as having undermined violaceous borders. It's kind of a buzzword for this. It's okay. I'll give you all the answer. So this can be a little bit tricky to diagnose because it can look similar to other cases that we've gone over. But this is pyoderma gangrenosum. You can see the raised border, the granulation tissue, the thick exudate. Something that's really characteristic about these lesions that if you see, you should definitely think about pyoderma gangrenosum is the undermined violaceous border. They're also sometimes referred to as ragged borders, which I don't think this is the best example. So I have another one here. You can really see the ragged edges, the violaceous undermined border. So if you see that, definitely think pyoderma gangrenosum. So when to biopsy and when to refer. So if the ulcer continues to expand or has had no improvement with various treatment modalities, this is when you should consider a biopsy. In the literature, the current recommendation is that if an ulcer does not show signs of healing after about 4 to 6 weeks of appropriate treatment, a biopsy is recommended. And then performing a biopsy on non-healing wounds is generally safe with a low rate of adverse events. And if in your clinic you don't do biopsies, or if you have a case that you're particularly uncomfortable biopsying, this would be a good time to refer to dermatology. They can get that biopsied and sent to pathology so we can get a definitive diagnosis. And then 2 quick key takeaways. So you must consider neoplasia in a poorly healing leg ulcer. And you can biopsy as early as 4 to 6 weeks if there's no signs of healing after appropriate treatment. And so that is all I have for you guys. I appreciate y'all participating.
Thank you, Sarah. That was very interesting. And of course, these are things that are very challenging for us all out in the primary care setting. I did have a question, and I'm looking again. I'm monitoring the chat. I don't see anything over there, but there are oftentimes, especially if someone gets sent off for Mohs surgery, and then there's a reconstructive effort and those sorts of things. But those specialists may be an hour or 2 hours away from where the primary care referring doctor or nurse practitioner or PA is. And so if there's oftentimes an opportunity or a need for the primary care provider to do some of the supervision of the healing process in that. Can we talk, or maybe I see we have a Mohs specialist, Dr. James is on here. Can we have someone talk a little bit about how that wound might have been handled? Because you had a lesion that was removed by Mohs surgery. I believe it was a basal cell, but we didn't see what happened to it after that. Maybe we could talk a little bit about how that wound might be managed, and if there's some tips and tricks for those of us who are working in primary care settings on how we can help with that. Just jump in, Sarah, and if you don't, if you need some help, then we'll call on Dr. James.
Yeah, I think I might phone a friend for this one.
Okay, we're phoning a friend. Dr. James, are you with us? Might have been called away. Okay. Well, we have, there we go. We have Dr. Davis. I was just fixing to call your name.
Well, I was just gonna say that, you know, secondary intent healing is great, and we do use Una boots when things start to turn the corner. So we'll put Una boots over a Mohs defect. And we'll use Duoderm dressings prior to that if we feel like we need to monitor it a little bit more closely initially. So leg elevation, Duoderm dressings, support stockings, Una boots, all of those things are great, especially for the non-compliant patient. Una boots are great. And then getting back to what Caitlin said, making sure that you stop any drugs that are causing leg edema. And there are many out there. So, I mean, there's a nice list that we can just keep adding to, but any any type of amlodipine, calcium channel blockers, gabapentin, Lyrica, hydralazine. I mean, the list goes on and on and on. So we always check that too. But from our standpoint, we always try to get our primary care folks involved with changing the meds and doing dressing changes, especially in the boots.
That's great. Thank you, Dr. Davis.
Mhm.
Any other comments or questions? We have just a few minutes left before we have to go.
I was just gonna say, I think that one photo that Sarah showed of pyoderma, it had that sort of like classic cribiform pattern, which we can see. So that was a really good example, and it's a really hard diagnosis to make. But you know, we've seen cases where these were treated with debridement, and then you know further sort of worsened the wound, and then you know, had to do oral steroids, things like that. So it can sometimes be an easy diagnosis to make, especially when you hear those buzzwords, but also really challenging at the same time and challenging to treat as well.
So what are some of the easy ways to treat this before it gets to the point of inadvertent debridement that's necessitating, systemic steroids and things like that? What should we do before we get?
I think just like recognizing that it's not, you know, one of the more common things like venous or arterial or diabetic. And then, you know, if those standard treatments fail, you know, occasionally we will have to do a biopsy. No one likes to biopsy the lower leg, but usually if it's really small, starting out with topical steroids is fine. And then if it continues to progress, then that's when, you know, dermatology may need to get involved to do intralesional Kenalog, things like that. So
Very good. Where's the most common location for pyoderma gangrenosum?
ooh, I might have to phone Caitlin for that. I think it's the lower legs, but I'm I'm blanking on my board spotter right now.
That's all right. I think Dr. Davis is affirming your best guess. So
Yeah, it's definitely the lower leg. I think it's when it's not on the lower leg, that's what's tricky. And I mean, we've seen them on, the breast, the buttock. I mean, perianally, periostomal PG is actually fairly darn common. But you want to ask those questions, in someone with inflammatory bowel disease or rheumatoid arthritis. Those are definitely folks who'd be predisposed to having pyoderma gangrenosum. The patient where it just doesn't make sense. And it's very painful too. So unlike a venous ulcer, I mean, PG is extremely painful. And, I think we shouldn't be afraid to do a biopsy of the perilesional skin if we need to. But debriding a PG lesion is really problematic. And that's when we tend to see folks.
especially on the areas where you have very little subcutaneous cushion.
Exactly.
Great. Well, once again, Dr. Davis, your overall appreciation for systemic medical issues and bringing that to bear in the conversation is deeply appreciated. So that's great.
Fun.
Well, I don't see any other questions or comments. Brenda did put a link in there to the website for our programs. And at that website, you can navigate around to find archived previous presentations and things like that. So So there's the other information. And with that, I'm going to wrap it up and turn it back over to Dr. Markowitz.
Okay, what a great discussion today. I really like the exchange that was going on. And so I want to thank all the participants, certainly Caitlin for your presentation, and Sarah for yours, and Dr. Rabinovitz and Dr. Buchanan for helping Sarah. And let's see, our next session will be May 5th, and the didactic is will be presented by Dr. Sally Young, a PGY2 resident, and it will be on herpes simplex versus zoster. So that should be interesting. We don't have the exact name of who will be doing the case presentation, but I would like to say that most of our cases have been presented over the past year or so by medical students, but we really would like to have case presentations from some of you clinicians out there in the field. And so any one of you who would like to present, please contact Brenda. And both Brenda and Dr. Buchanan will be able to help with the presentation. The cases don't have to be as detailed as the ones that our medical students have done. Just one of your patients with pictures and symptoms, no PHI. Want to make sure about that. But and diagnoses or discussions would be really great. So please contact Brenda, and if Brenda contacts you, I hope that you will say, I'll be glad to do one. So this is a safe environment for it. For CME credit, the code is on the slide, 22779. Remember that you have to be registered with the MCG continuing education. If you have a problem with that, again, contact Brenda, teledermatology at augusta.edu. And Brenda also wanted me to let you know that when she sends out the email about the CME, that she will also be sending a link for a survey, which is sort of an end of the year survey. We're not quite the end of the year yet, but a survey and on what you've learned, or what, you know, these surveys help us plan and evaluate what we've been doing, and they're very necessary for us. So we really hope that you'll take the 5 or 10 minutes to fill out the survey. And I'm looking, have I left anything else out? Not that I can think of, but again, thank you all for the presentations and the discussion. That's what this is. That's what this Project Echo is all about, is sharing information. And so I think today's session was a really great example of that. And we'll see you hopefully on May 5th. I guess that will just be 3 weeks from now, since this one was late. So we'll see you on May 5th to learn about herpes and zoster. So if I can remind our TeleDerm Hub team to stay on board for a few minutes, and the rest of our guests can sign off now. So thank you.
Thanks, everyone.